Hello and welcome back. One of the most common things I hear from people struggling with SIBO is, I don't understand why this keeps coming back. Maybe you did a round of rifaximin and felt better for a while. Maybe herbals helped temporarily. Maybe you were really strict with your diet and symptoms improved, but then slowly started creeping back again a few weeks or months later. And after enough failed rounds, a lot of people start feeling completely defeated and confused. Like, did I miss something? Am I doing something wrong? Do I just need a different treatment? Why does this keep happening? And honestly, I think one of the biggest problems in the SIBO space is that relapse is often discussed in a way that's way too simplistic. Because yes, bacterial overgrowth is part of the picture, but recurring SIBO is not just about bad bacteria coming back. A lot of the time, it's about the larger gut environment underneath the overgrowth itself. Things like impaired motility, digestion issues, chronic constipation, nervous system dysregulation, microbiome depletion, structural issues, post-infectious changes, or honestly, usually multiple overlapping contributors all at the same time. And that's why I tend to call them root contributors instead of root causes, because root cause sounds to me more like a singular thing. And in most cases, there are more than one thing happening that creates the gut environment that allows SIBO to occur in the first place and then continue to relapse when not addressed. Because when those larger contributors never really even get identified, much less addressed, it makes sense why someone can keep falling back into the same cycle over and over again. So, in today's episode, I really want to zoom out and talk about the bigger picture behind SIBO, not just the bacteria itself, but the underlying gut environment that allows the overgrowth to happen in the first place and continues to keep the gut vulnerable to relapse over and over again unless it's addressed. Now, a lot of people still picture SIBO as bacteria from the large intestine that somehow crawls backward or reflux up into the small intestine where it doesn't belong. And to be fair, that actually was the original way that SIBO was commonly thought about for many years, almost like bacteria from the colon was backflowing upward and colonizing the small intestine. But our understanding of SIBO has evolved quite a bit over time. The small intestine is not supposed to be completely sterile. There are small amounts of bacteria that are normal. The key is that under healthy conditions, food and bacteria are constantly being moved through the small intestine and kept appropriately regulated by the gut's natural defense systems. So that would be normal small intestinal motility, which includes the migrating motor complex, which we will touch on in a minute, stomach acid, bile flow, digestive enzymes, and immune defenses within the gut lining that all help prevent excessive bacterial buildup and stagnation. So, in other words, SIBO is often less about bacteria coming from the wrong place and moving into the small intestine, and it's more about the small intestine losing its ability to efficiently regulate and clear bacterial load over time, which eventually allows the bacterial overgrowth to happen. So, when systems are working well, the gut is generally able to manage normal bacterial exposure without it progressing into SIBO. And when the gut environment becomes disrupted, maybe chronic stress starts affecting the nervous system's regulation of digestion and motility, or stomach acid production drops, or bile flow becomes sluggish, maybe immune defenses become compromised, motility slows down, or chronic constipation develops. Bacteria and food residue can linger in the small intestine longer than they should. And over time, that's what creates an environment that becomes more favorable to overgrowth. And this is one of the biggest gaps I see in the way SIBO is often approached online or even clinically. The conversation tends to focus almost entirely on lowering the bacterial numbers, but far less attention is given to why the gut environment became vulnerable to overgrowth in the first place, or what actually needs to recover in order to progress and last long term. Because if the underlying environment is still struggling to properly regulate bacterial balance, simply lowering the bacterial numbers temporarily does not mean the systems that allowed the overgrowth to happen are actually recovered. In our practice, this is one of the biggest areas we focus on is with our clients is helping them break the relapse cycle. We are not just thinking about how to lower the overgrowth temporarily. We are also looking at the underlying systems involved in motility, digestion, nervous system regulation, gut resilience, and overall intestinal function that may still be making the gut more vulnerable to recurrence over time. Another big misconception I see around SIBO is simply about just bacterial overgrowth being present. But in reality, the body has multiple built-in systems that are supposed to help regulate bacterial levels in the small intestine naturally. And so what I explain all the time, it's not just a bacteria problem. SIBO is often a systems problem. Your gut is constantly exposed to food, microbes, and bacteria throughout the day. Under healthy conditions, the digestive tract has several different mechanisms working together to keep things moving, properly broken down, and appropriately regulated so bacteria do not accumulate excessively in the small intestine. One of the most important of these systems is something called the migrating motor complex, or you'll hear it referred to as the MMC. And that is basically a series of cleaning waves that occur between meals and help sweep leftover food particles and bacteria through the small intestine. I sometimes explain it to clients like this. Your small intestine is kind of like your dinner plate, where food is being served up and processed throughout the day. If you leave dirty dishes sitting around without washing them, how long does it take before they start getting funky and growing bacteria? The same thing happens in the small intestine when these cleansing waves are not efficiently clearing leftover food particles and bacteria between meals. That's also why meal spacing can matter in a lot of SIBO cases. Constant grazing throughout the day does repeatedly interrupt these cleansing waves, meaning the small intestine never gets the opportunity to fully clear itself out between meals. Using the same analogy, that would be like continuing to use the same plate all day long without ever really washing it off in between. Before long, that plate is probably going to start getting a little funky with bacteria growing all over it. Meal spacing essentially gives the gut a chance to wash the plate, clear things out, and start fresh again before the next meal comes in. And motility is one of the primary issues in most SIBO cases. Decreased small intestinal motility or decreased MMC function for a variety of reasons is the most common root cause of SIBO. But that's not the only system involved in regulating bacterial balance in the small intestine. Stomach acid, bile flow, digestive function, immune defenses, and overall nervous system regulation can also influence. They all play a part in influencing how effectively the gut is able to manage bacterial exposure and maintain balance over time. Stomach acid plays a really important role because we are constantly swallowing bacteria all day long from food, from our saliva. We swallow a lot of saliva throughout the day, and there's bacteria naturally living in the mouth. Even if you have issues with gum health or dental issues, there can be actually significant amount of bacteria that you're swallowing throughout the day. And most people don't really think about how much saliva or bacteria they're swallowing throughout the day. You probably don't, but it's actually a lot. And under healthy conditions, a stomach acid is one of the body's major defense systems against all of that. It helps to sterilize a lot of what comes into the digestive tract before it moves downstream. But when stomach acid gets impaired, the gut can become a lot less efficient at regulating bacteria levels higher up in the digestive tract. And honestly, chronic stress is a huge one here that I think gets massively overlooked because when somebody is stuck in chronic fight or flight mode for long periods of time, the nervous system starts downregulating a lot of normal digestive signaling, including stomach acid production. I explain this to patients all the time because digestion is not just something the body prioritizes very well when it feels really stressed or unsafe. It actually gets downregulated, deprioritized. Also, long-term use of acid-reducing medications like antacid or proton pump inhibitors can play into this too. Other things like H. pylori, aging, just getting older, you produce less stomach acid over time. Poor digestive signaling for a number of reasons and other factors can contribute to low stomach acid as well. Bile is actually another huge piece that I think gets overlooked in gut health conversations. Most people only think about bile in the context of fat digestion, but bile actually plays several really important roles in helping to regulate the gut environment. It has natural antimicrobial properties and also helps support healthy movement through the digestive tract and helps keep things from becoming overly stagnant higher up in the intestine. When bile flow becomes sluggish, and this can happen again from chronic stress, impaired nervous system signaling, gallbladder issues, undereating, restrictive dieting, or other digestive dysfunction, the gut environment can become much more favorable for bacteria to linger and accumulate over time. Digestive enzymes matter too. When food is not being properly broken down and absorbed efficiently, you have partially digested food material that remains available as it moves through the intestine for bacterial fermentation. So it should normally be broken down more as it travels through, but when we don't produce enough enzymes, it remains intact to feed bacteria. Even the immune system within the gut lining plays a role too. Your intestinal tract is not just like this tube that passively moves food through. It's an active, highly intelligent barrier system that's constantly interacting with microbes and helping to regulate what belongs, what does not belong, and how much bacterial exposure the gut can appropriately tolerate. And when you really zoom in on the intestinal lining itself, it is honestly more like a bustling city than a simple tube. Different cells and parts of the gut lining all have different jobs that they're constantly carrying out. Things like helping to regulate immune activity, communicating with microbes, maintaining the health of the barrier, producing protective compounds, absorbing nutrients, and deciding what gets allowed through versus needing to be kept out. So there's an incredible amount of communication, regulation, and decision making happening there all of the time. And then, of course, there's the overall intestinal clearance and movement through the digestive tract. If food, waste, and bacteria are sitting too long in the GI tract, whether it's from chronic constipation, pelvic floor dysfunction, decreasing your ability to pass stool, nervous system dysregulation, structural issues, adhesions, or other contributors affecting healthy intestinal movement and outflow, the gut environment becomes much more favorable to overgrowth. This intestinal movement issue is probably the closest thing to the more traditional kind of everything backing up picture people often associate with SIBO. So that is one of the potential issues. It's just not the whole story. And that's why I think it's so important to stop viewing SIBO as simply killing the bacteria. Because when you really zoom out, bacterial balance in the small intestine is being regulated by multiple systems at the same time. And if those systems are still struggling, simply lowering bacterial numbers does not mean that the gut environment that allowed the overgrowth to develop has actually recovered. And this is why, if you Google SIBO, you will constantly read about SIBO having high relapse rates. And it makes it feel pretty discouraging because it kind of makes it feel like this is just something I'm going to deal with the rest of my life. There's no solution. But I can tell you in our practice, our experience is that when we look at these contributors comprehensively and support the broader gut environment in an individualized way, because as you can imagine, as we're talking through these details, every person is like a fingerprint. Every person has a different mix of things going on. And so when we pinpoint the root contributors, we address them in an individualized way. And we actually tend to see a pretty low rate of relapse overall in our practice. And really, this is one of the biggest reasons, again, that we call it root contributors instead of root cause, because the idea of finding one root cause is so common in the functional health space. But what we actually see is that there are usually multiple contributors. And while I know this may sound like a lot, I actually think this is one of the most hopeful parts of the conversation because once we start looking at all the different systems involved in regulating the gut environment, that gives us an opportunity to improve outcomes and do something about it. So hopefully this feels hopeful versus overwhelming because we see a very low rate of relapse when we address things. And we'll talk in a little bit about the people that are going to relapse because there are cases where we can't do anything about some of the underlying contributors. We'll get to that in a second. Now, let's talk about motility. I really want to clear something up here because one of the most common misunderstandings I see around SIBO, and I hear it from people every week, and even, gosh, even maybe some practitioners who may not be specialized in SIBO, the assumption that if someone has diarrhea or frequent bowel movements, slow motility cannot possibly be part of the issue. I actually had a client tell me recently that she lost confidence in a previous functional medicine practitioner that she was working with after they recommended a prokinetic to support motility. So a prokinetic is an agent, either prescription or herbal, that helps things move. It helps support that MMC function and helps move food and waste through the small intestine, out of the stomach, and through the small intestine. So her functional medicine provider recommended a prokinetic, and this person told me, that's when I lost confidence in this doctor because I have diarrhea. So a motility agent was not appropriate for me. And she even said, I had to explain to the doctor that motility activators are for constipation, not for diarrhea. And I completely understood why she was thinking that way because most conversations around motility are heavily focused on bowel movement frequency. But this is where it becomes really important to distinguish between upper GI motility, meaning stomach emptying and movement through the small intestine, and lower GI movement through the colon, because they are not the same thing at all. When we talk about SIBO and motility, we are often talking about the movement and clearing function of the small intestine and the migrating motor complex, which we touched on earlier. These cleansing waves help move food particles, bacteria, and debris through the small bowel between meals. And that is very different from how often someone is having a bowel movement. So when we think about bowel movement motility, we're talking about large intestinal motility. And there's different mechanisms that affect both of those types of motility and different agents we would use to stimulate those types of motility. So a person can absolutely have diarrhea, loose stools, urgency, or multiple bowel movements throughout the day while still having impaired clearing function higher up in the digestive tract. And I think this is one of the reasons SIBO can feel so confusing for people. They assume if things are moving quickly out of me, I'm having all this diarrhea, how could stagnation in the small intestine possibly be happening? How could I not just be clearing everything out? But the digestive tract is not just one long uniform tube functioning identically from start to finish. Different parts of the GI tract, they do behave differently all at the same time. In fact, it is entirely possible for somebody to have sluggish clearing waves in the small intestine leading to bacterial buildup, bacterial fermentation occurring too high up in the GI tract, poor coordination between different phases of digestion, and then urgency or loose stools further downstream in the colon. I sometimes explain this to clients like traffic patterns on the highway. One section of traffic can be heavily congested and poorly coordinated, while another section further down the road can be moving too quickly. So those things can coexist. And this misunderstanding is important because it is one of the reasons sometimes people will dismiss motility support or prokinetics too quickly or assume it does not apply to them if they are not constipated, even though impaired upper GI motility is one of the most common underlying conditions that causes SIBO. Now, to be clear, not every person with SIBO has a major motility issue, but impaired upper GI motility is still probably the single most common contributor we see associated with SIBO overall. So understanding that upper GI clearing function and lower bowel frequency are not interchangeable is a really important shift because it changes how we think about why overgrowth may continue to recur even after treatment. And really, this is one of the biggest themes throughout the entire episode. SIBO is often not just about what bacteria are present, it's also about how effectively the gut environment is moving, regulating, clearing, and managing everything passing through. So, what actually impairs the gut environment? Let's understand these underlying causes because at this point, the next question becomes what is disrupting these systems in the first place? And this is where I think the idea of root contributors becomes much more helpful than trying to find one single thing that causes SIBO. All right, some of the most common risk factors and contributor categories we look at clinically include the first one, the biggest one, is impaired motility. This is the single most common contributor that we see associated with SIBO. And one of the biggest and most well-researched drivers of this is post-infectious SIBO, where symptoms begin after food poisoning or acute gastroenteritis. Research has shown that a large percentage of IBS cases, particularly IBS-D, begin after these types of infections. So in some people, the infection may trigger an immune response that interferes with the migrating motor complex and normal cleaning waves throughout the small intestine longer term. So food poisoning is one of the most common root causes of SIBO. And when we're talking about impaired motility, we also see contributors like hypothyroidism, diabetes, autoimmune conditions like celiac disease, hypermobility syndromes like Ehlers-Danlos, and nervous system dysregulation, traumatic brain injuries, and chronic stress that may affect nerve signaling or muscular coordination over time. That's a big category. The next category is impaired digestion. This is another major contributor that we very often see in SIBO cases, and I think this conversation also gets oversimplified. As we mentioned earlier, digestion really influences bacterial balance in two major ways. The first way is that proper digestion helps break food down efficiently before it reaches further downstream in the digestive tract. So, when stomach acid, digestive enzymes, or bile flow, or just digestive signaling in general becomes impaired, food remains only partially digested higher up in the small intestine, providing more material available for bacterial fermentation, where it was really never meant to linger in large amounts. The second mechanism, as we talked about earlier in the article, is that stomach acid and bile also help act as important defense systems against excessive bacteria survival higher up in the GI tract. We are constantly swallowing bacteria throughout the day through food and saliva and the environment around us, and proper digestive function helps to regulate how much of that bacteria load survives and moves further downstream. So, more simply, stomach acid and bile have antimicrobial effects. And there are a lot of things that can impair this digestive function over time. Low stomach acid, poor enzyme output, poor bile flow, gallbladder dysfunction, chronic stress, chronic undereating, restrictive dieting, impaired vagal tone, rapid eating, and long-term nervous system dysregulation can all interfere with how efficiently the digestive tract is functioning upstream. The next big category is impaired outflow. This is a category that gets massively underestimated, especially in constipation predominant cases. If things are not moving well downstream, the entire gut environment can become more stagnant over time. Chronic constipation, pelvic floor dysfunction, sluggish bowel movements, structural issues, adhesions from prior surgeries, endometriosis, or impaired coordination of the pelvic floor muscles, or poor downstream motility. These can all contribute to this picture. And this is where that everything backing up analogy people associate with SIBOs can play in. I think many people underestimate how interconnected the entire digestive tract really is. the body is not separating the small intestine and colon into completely isolated systems. So if downstream movement becomes sluggish enough, it can absolutely influence pressure, stagnation, microbial balance, and overall movement patterns further upstream. Pelvic floor dysfunction in particular is something I see that's just hugely under-recognized in chronic constipation cases. Some people are pushing, straining, or just always feeling incomplete, like they're not passing all of the stool. And it's not necessarily because the stool is too hard, it's because the coordination of the muscles involved in elimination are not functioning optimally. So you have to have muscles that are contracting while other muscles are relaxing at the same time in order to release stool. And that those muscles can become discoordinated so that downstream emptying is chronically impaired, and that can absolutely contribute to a more stagnant gut environment overall. Another big one is nervous system dysregulation. This one I think is just so underappreciated, although we're getting better about it. We are definitely bringing this up more and more and hearing more and more about it in gut health conversations. So the gut and nervous system are deeply connected. Digestion is not something the body prioritizes particularly well when it feels chronically stressed, unsafe, overstimulated, or stuck in long-term fight or flight mode. Chronic stress, burnout, trauma, hypervigilance around symptoms, poor sleep, nervous system dysregulation, or just constantly being on can all influence motility, stomach acid production, digestive coordination, gut sensitivity, immune signaling, and overall digestive resilience. And one thing I've noticed clinically is that many people do not necessarily recognize how much chronic stress their body has been carrying until their digestive system starts becoming more reactive, more inconsistent, or more sensitive. I want to be really clear about this. This does not mean symptoms are just stress or just anxiety, not at all, or just in your head. What this does mean is that stress causes actual, real physiological effects on the digestive system. So the nervous system absolutely plays a major role in regulating digestive function behind the scenes, and stress can interfere with that role. Also, we see post-infectious changes. There are people that can pinpoint the exact moment their digestive system changed. Maybe it started after food poisoning while traveling, or a severe stomach bug, or a C. diff infection, or COVID, or norovirus ripping through the entire household, or some other major gastrointestinal infection where the gut just never seemed to fully recover afterward. And truly, this is one of the reasons so many people feel confused about their symptoms, because from their perspective, it can feel like I got sick one time and my digestion was just never the same after that. In some people, the gut eventually regains its previous rhythm and resilience over time, but in others, infections may leave behind lingering changes involving motility, immune signaling, microbial balance, gut sensitivity, and digestive coordination that continue affecting symptoms long after the original infection itself has passed. Next, we have medication-related contributors. Medications can absolutely influence the gut environment too, although this is another area where the conversation often becomes oversimplified. For example, acid suppressing medications like PPIs may reduce one of the body's major defenses against excessive bacterial survival higher up in the digestive tract. Repeated antibiotic exposure can sometimes disrupt the microbial balance and resilience over time, and opioids may significantly slow motility and intestinal clearance. I also think some of the IBS medication conversations become really interesting here because there can sometimes be a bit of a double-edged sword effect. So, some medications commonly used in IBS are specifically designed to slow intestinal movement or reduce spasms or calm gut sensitivity in order to help improve symptoms like cramping, urgency, diarrhea, or visceral hypersensitivity. antispasmodic medications like dicyclamine and certain tricyclic antidepressants like amitriptyline can absolutely be helpful tools for someone who has those symptoms. But at the same time, if a medication is intentionally slowing intestinal movement and transit, you can also start to see how that can contribute to more stagnation and impaired clearance upstream. So, the next category is microbiome depletion and chronic restriction. And ironically, some people actually become more microbiome depleted and reactive after years of trying to fix their gut. This is something I see especially often in people who have spent years cycling through restrictive diets, repeated antimicrobial products, chronic food elimination, fear around food, chronic undereating, or constantly trying to remove more and more foods from the diet. I worked with one client who had spent years cycling through repeated antimicrobial protocols and increasing restrictive diets, trying to keep her symptoms under control. And to be fair, many of those approaches did help temporarily at first, but each time she would feel somewhat better for a while, and then the symptoms would slowly creep back again and again, which led to another round of restriction, another round of treatment, and another list of foods to eliminate. But over time, something interesting started happening with her. Instead of her digestive system becoming more stable and resilient, it seemed to be becoming more fragile with increasing food reactivity, reduced tolerance to foods over time, and even concerns about potential vitamin deficiencies from how limited her diet had become. Foods she had tolerated suddenly started bothering her. Her safe foods were no longer safe. Her diet became narrower and narrower over the years, and she had also started experiencing unintended weight loss from how limited and restrictive eating had become for her. So she noticed that even small deviations from her safe foods would sometimes trigger bloating, abdominal pain, discomfort, and other symptoms that really just felt disproportionate to what she was eating. So things were just sliding in the wrong direction. And I think this is one of the biggest things people sometimes miss in chronic gut issues is that many situations repeatedly focusing on just suppressing bacteria or just killing bacteria and removing more and more foods, it actually leaves people with a digestive system that feels less adaptable and less resilient over time, not more resilient. And that's because we are changing the microbial environment. When we're killing off bacteria and we're not feeding them with a diverse diet, we're actually making your microbiome more sensitive. So, a helpful way to think about the microbiome is like a garden ecosystem. If you constantly keep stripping things away, over pruning, spraying everything down, and reducing diversity more and more over time, eventually the entire ecosystem becomes weaker and more fragile. And to be clear, when I'm talking about microbiome depletion here, I'm primarily talking about the large intestinal microbiome. I'm not talking about the small intestine here. We're talking about large intestine depletion that happens alongside the things we're doing to try to target the small intestine. And I think this distinction really matters because we are talking about two different bacterial locations and both are affected here. So, we still don't fully understand the exact ways that a depleted large intestinal microbiome can contribute to recurring SIBO patterns specifically, but what I can say is that in practice, I very commonly see people with extremely depleted, less resilient microbiomes also struggling with recurring SIBO and increased food reactivity and reduced tolerance to normal dietary variety. I recently listened to a practitioner talking about how she finally stopped her own chronic SIBO relapse cycle after years of trying like all the standard approaches. She had tried many different rounds of prescription antibiotics and herbal antimicrobials. She had tried prokinetics. And what ultimately made the difference for her finally and stopped her chronic relapsing was she shifted away from trying to like keep killing the bacteria and she started focusing more on heavily rebuilding her microbiome. So she described a targeted probiotic regimen she went on and just an overall microbiome supportive dietary approach. And that was really cool because she explained that over, I think it was about a 6 month period of time. So microbiome repletion doesn't happen overnight, but she was finally able to stop relapsing after years of having SIBO. And that's just really interesting to those of us that work with SIBO, because again, she didn't do anything directly to target the small intestine, but she drastically improved the large intestine microbial environment. So that points to the fact that there is a connection there in some cases. And the research is still out on this, and there are people and there are studies where probiotics, for example, are extremely helpful for SIBO. And then for a lot of people, it's an interesting part of the conversation. Structural and mechanical issues are another category that I think is massively overlooked in SIBO conversations, even though I see this come up super often in practice. And once people start thinking about it, the light bulb usually goes on pretty quickly because think about it. How many people do you know who have had some kind of abdominal surgery at some point? Things like C-sections, appendix removal, hysterectomy, endometriosis surgery, hernia repair, gallbladder removal. These things are incredibly common. And the reason this matters is because any abdominal surgery has the potential to create adhesions, which are essentially bands of internal scar tissue that can form as the body heals. And sometimes those adhesions can cause parts of the intestine or surrounding tissues to stick or pull in ways that they normally would not. Normally, the intestines are able to move and glide relatively smoothly throughout the abdominal cavity, but adhesions can sometimes create areas where the intestines become tethered or kinked or compressed or pulled awkwardly or restricted in their movement. And you can start to imagine how that may potentially affect flow, pressure, movement, and stagnation within the GI tract over time. So food and bacteria can just get stuck in these nooks and crannies that form as a result of adhesions. So this does not mean that every person with abdominal surgery in their history is going to develop SIBO, not at all. But I do think that structural and mechanical contributors are one of those areas that often gets missed entirely because people are so focused only on the bacteria itself rather than the environment, the broader environment that is in and around where the bacteria are living. So now that we've talked about the different contributors to what creates a landscape that allows SIBO to develop, let's talk about what relapse prevention actually looks like. One of the biggest misconceptions I see is the idea that the relapse prevention in SIBO is about finding one maintenance strategy to stay on long term, whether it's a prokinetic or a supplement or a diet or some kind of way to keep bacteria down long term. Really, relapse prevention looks very different depending on which underlying contributors are actually driving the overgrowth. So, for someone dealing with impaired motility, relapse prevention may involve things like meal spacing. Remember to give that opportunity in between meals for the MMC to move food and bacteria and debris through. Prokinetic support to help stimulate those clearing waves through the small intestine, improving bowel regularity downstream through a number of different ways, looking at deeper contributors like hypothyroidism, diabetes, hypermobility syndromes, or nervous system dysregulation that may be impairing that intestinal clearance in the first place. So that might involve prescription approaches, sometimes herbal options, or a combination of strategies and therapies that would involve maybe different medical providers that would be helping you with those particular areas. For somebody dealing with impaired digestion upstream, the focus may shift much more toward improving how food is actually being broken down and processed before it reaches further downstream. So, depending on the situation, that might involve supporting stomach acid, digestive enzymes, bile flow, vagal nerve tone, and digestive signaling around meals through things like slowing down while eating, engaging the senses around foods, digestive bitters, smelling a lemon before you eat to make yourself salivate. Remember, with bitters and through sensory methods like smelling a lemon or smelling each bite of food before you eat, you stimulate salivation, which also helps to stimulate enzyme release, stomach acid release, bile release, kind of down the line. That's what we mean by digestive signaling, getting into rest and digest mode at mealtime to allow that signaling to occur. Yeah, helping with vagal tone, or it could look like supplementing with digestive support, like enzymes, acid support, things like that. And in some cases, the goal, we're either helping the body stimulate your own secretions or directly replacing support because the body is just not producing what it needs. If impaired outflow is a major contributor, relapse prevention may involve improving bowel regularity, addressing chronic constipation, supporting downstream motility, like working through pelvic floor dysfunction with a trained practitioner, a pelvic floor physical therapist, because that dysfunction could be impairing elimination and downstream emptying. And depending on the situation, as far as just addressing constipation, it might look like magnesium or other osmotic support to improve that bowel regularity, sometimes stimulant laxative support, or pelvic floor physical therapy, bowel retraining strategies, improving toileting mechanics, maybe having your feet up on a stool so you're improving the position on the toilet. Those are sitting for a certain amount of time each morning to retrain the bowel to have some regularity. If we're talking about nervous system dysregulation playing a major role, relapse prevention may involve things like improving sleep quality, nervous system regulation around meals, vagus nerve support, like maybe vagal nerve stimulation, vagal nerve exercises to tone the vagus nerve, gut-directed hypnotherapy, cognitive behavioral therapy, somatic work, breath work, or other strategies to help the body shift out of chronic fight or flight patterns that can impair digestion and gut coordination behind the scenes. For people with post-infectious motility issues after food poisoning or gastrointestinal infections, relapse prevention may lean more heavily toward meal spacing and long-term prokinetic support to help compensate for impaired cleaning waves through the small intestine and support the migrating motor complex between meals. If medications are contributing to the bigger picture, sometimes relapse prevention may involve reevaluating whether certain medications could be affecting motility or digestion or stomach acid levels or microbial balance in ways that are unintentionally contributing to stagnation upstream. For someone who's severely depleted in their microbiome after years of restricted diets or repeated antimicrobial protocols, or chronic food fear, the focus may shift much toward rebuilding the microbiome resilience through things like carefully expanding dietary diversity, strategically using prebiotics and probiotics when appropriate, improving tolerance of foods over time, and in some cases, even gradually, I love to, with our clients, have them gradually move toward a more diverse Mediterranean style or plant forward way of eating to better support long-term microbial stability and a healthy microbiome. Of course, once their system is ready for it and the SIBO has been fully cleared. And for people dealing with structural or mechanical contributors, relapse prevention may sometimes involve specializing manual therapies or visceral manipulation aimed at improving mobility and movement between abdominal tissues that may have become restricted by adhesions or prior surgeries. So essentially, those therapies can help restore better movement and reduce areas of tension or pulling or restriction that may be affecting how the intestines are able to move and glide within the abdominal cavity and how food and waste are able to move and glide through the intestines. And this is exactly why relapse prevention in SIBO is rarely as simple as just taking one thing forever. The real goal is identifying which systems in the gut environment became disrupted in the first place and helping stabilize those systems long term. And for many people, it's not just one thing, it's often layering together multiple strategies at the same time based on the specific contributors involved. Now, Earlier in this episode, I did talk about how when we identify the root contributors involved, address them comprehensively, and build a personalized plan around them, we see a very low rate of relapse in our practice. But I also want to acknowledge that not everybody is going to be able to fully prevent relapse. And a big reason for that is because not all root contributors are things we can do very much about. There are contributors we can support and improve significantly once we identify them. But other contributors, like profoundly impaired motility, major structural changes, altered anatomy, severe neurological dysfunction, or extensive adhesions, may only be partially reversible or sometimes not very reversible at all. And those are often the situations that fall more into what I think of as chronic relapser territory. And that can include specifically things like severe slow transit, constipation, significant post-surgical anatomical changes to the GI anatomy, major adhesions or structural restrictions, connective tissue disorders like Ehlers-Danlos syndrome, profound pelvic floor dysfunction, severe post-infectious motility impairment, neurological conditions affecting GI motility, including traumatic brain injuries, inflammatory bowel diseases like Crohn's disease, when chronic inflammation or strictures or narrowing have significantly altered movement through the GI tract. Or, of course, situations where there are multiple major contributors all happening at the same time. And this is where the conversation around relapse prevention becomes much more nuanced, because in some of these cases, the goal shifts away from how do we make sure this never happens again toward how do we manage this proactively to keep things from spiraling badly again. So, for example, I recently spoke with a patient who had an extremely severe chronic relapse pattern involving hydrogen dominant SIBO, severe slow transit constipation, pelvic floor dysfunction, Roux-en-Y gastric bypass surgery, pancreatic insufficiency, and profoundly impaired motility testing showing dramatic delays in movement. She had already been through multiple long antibiotic courses over the years and would improve partially each time, but the overgrowth kept rapidly returning. Despite years of treatment, nobody had ever actually repeated breath testing afterwards to see how much clearance had occurred. Her most recent hydrogen levels were actually above the upper cutoff of the lab, meaning we don't even know how high they were. This is exactly the kind of situation where repeatedly doing more antibiotics without a bigger long-term strategy stops making sense. At a certain point, you have to step back and recognize that if someone has profoundly impaired motility and altered GI anatomy, the overgrowth is most likely going to keep returning unless you approach the situation differently. So in her case, the first priority becomes clearing the overgrowth as fully as we can, which we may be able to do to a much larger extent than has happened with single kind of spaced out courses of antibiotics. So we decided in her case to use the elemental diet approach rather than just giving her more and more antibiotics or antimicrobials. Because in cases where bacterial burdens are this high, elemental diets are often able to lower bacterial levels much more quickly and thoroughly than antibiotics can without the big hit to the microbiome as well. And then the long-term management strategy becomes just as important, because realistically, someone with severe motility impairment and altered anatomy will still remain much more relapse prone even after we've successfully knocked the bacteria down. So instead of waiting until symptoms spiral out of control again and starting from scratch anytime, what we're generally looking at is recognizing the early signs of backsliding, catching it earlier, and preventing the overgrowth from ever becoming that severe again. In some chronic relapser cases, there may even be a fairly predictable cadence to those relapses over time, which allows us to use smaller, more proactive interventions periodically to keep up with things and to keep things more stable and manageable long term. So I think this distinction matters a lot. Chronic relapser does not mean somebody is hopeless or doomed to fail. Sometimes it means simply that we are dealing with a much more complex long term physiological situation that requires a different strategy where we are expecting a certain cadence of relapse and we are getting ahead of it proactively with a management strategy that's longer term. All right. Well, this has been a really hefty episode. We've talked through a lot. And one of the things I guess I really want you to take home from this is understanding that recurring SIBO is often much more complex than just the bacteria growing back. And in most cases, there are underlying patterns involving motility, digestion, nervous system regulation, microbiome resilience, structural issues, altered anatomy, or other contributors that are shaping the gut environment underneath. And I think this is one of the reasons so many people end up feeling stuck and frustrated after going through repeated rounds of treatment without lasting progress. Because if the bigger picture never gets evaluated, then it never gets addressed. And it makes sense why symptoms keep cycling back over and over again. But the good news is that once you start looking out at the full picture, zooming out from that small intestine and looking at the full picture more comprehensively, there are often far more opportunities to improve outcomes than people realize. And even for people who do fall more into that chronic relapser category, that does not automatically mean you are doomed or that your gut can never improve. Sometimes it just means the strategy needs to become more personalized, more proactive, and much more focused on long-term stabilization and support rather than repeatedly starting from scratch every time symptoms flare. And this is exactly the kind of work we do all day long in our practice at Nutrition Resolution. We spend a lot of time helping people step back, connect the dots, and understand what's actually driving the bigger pattern underneath their symptoms rather than just chasing temporary symptom relief over and over again. So, if this episode resonated with you, I'd really encourage you to check out my free masterclass called Why Your Gut Isn't Better, the real reasons you feel stuck and what to do about it. Because in that masterclass, I go even deeper into a lot of the bigger picture patterns that we talked about today. It's more, maybe not deeper into the relapse, but deeper into the fuller process of how we work with these cases. And as always, thank you so much for listening to the Gut Health Dialogues, and I will see you back here next week.